So there are a number of treatment options for pancreatic neuroendocrine tumors that are metastatic. They include somatostatin analogs, sunitinib, everolimus, 177 ludotatate, and we also have been starting to use temozolomide-based treatments. However, there was not a large randomized prospective trial using these agents. So we conducted, through the National Clinical Trial Network of the NCI and ECOG-ACRIN, a randomized phase II study of temozolomide alone or temozolomide and capecitabine together. This was a randomized study, 1-to-1 of 144 patients, so 72 on each arm. And the reason we wanted to do this study was to get prospective information on temozolomide, also because many of the other FDA-approved agents do not yield objective responses. So many of those agents, somatostatin analogs, sunitinib, everolimus, yield stability, but don't actually shrink the tumors. And there are a subset of these patients who either have rapidly progressing disease or high volume disease or symptoms from bulk or hormones that actually need shrinkage. And so in this study, the primary endpoint was progression-free survival by local review. Secondary endpoints were response rate, overall survival, and toxicity. And then some of the exciting news we presented today was around a correlative endpoint looking at a DNA repair enzyme called methylguanine methyltransferase, or MGMT, that in glioblastomas, so a totally different tumor type, that MGMT deficiency is actually predictive of response to temozolomide. So happy to go over the results of the study. We presented the progression-free survival data at the interim analysis in 2018. So this is really an updated analysis, but just to remind the audience, so the progression-free survival, we met the primary endpoint. The median progression-free survival was longer in the combination arm at 22.7 months versus 14 months in the single agent arm. So an absolute difference of about 8 months with a statistically significant hazard ratio and p-value. The updated analysis, we presented the overall survival data. There was not a statistically significant difference in overall survival. The difference was in the temozolomide alone arm, it was 50 months median OS, and in the combination arm, 58 months. So there was a clinically meaningful difference of about 5 months, but it did not reach statistical significance. And then in terms of the MGMT data, we evaluated MGMT by 2 methods. One is through immunohistochemistry and the other through promoter methylation. And we found that MGMT is in fact associated with response. We could not test whether it was a predictive biomarker in this study because both arms contained temozolomide. But what we found is that by both methods, we see that patients who had a response were also MGMT deficient, and that was statistically significant. And then, so I think in terms of like takeaways for the audience, CAPE-TEM, which is the abbreviation, has really already made its way into guidelines. So I think this reinforces that as a really standard regimen for patients with advanced pancreatic neuroendocrine tumors. In terms of whether or not we use MGMT in practice, I think it's not yet recommended for routine use for all patients, but for those patients who are in fact in need of an objective response, I think it's reasonable to consider testing those patients.